Thank you. It's my privilege today to talk to you about advanced issues in MMPI-A-RF interpretation. I think, this is my theory, we're going to deal with didactic issues for about 45 minutes, and we should cover 2 cases in the next 30 minutes, and we should have 15 minutes left for questions. That's theoretical because this is the first time I've done this workshop, so we'll all find out together just how good my time estimation is. In terms of disclosures, I receive royalties on the sale of products related to both the MMPI-A and the MMPI-A-RF. This webinar that I'm doing today, which is the first in the series of advanced webinars on the MMPI-A-RF, assumes that you have basic knowledge on the MMPI-A-RF. Excuse me. If you don't, I'd like to direct your attention to ways of getting that information. There is a webinar through Pearson on the MMPI-A-RF basic overview done by Richard Handel, which is, I'm sure, on the Pearson website that you can sign up for. There is a MMPI-A-RF introductory workshop that will be done through the University of Minnesota Press, their test division. It is, you can go to their website. It is going to happen this year, June 12th through June 15th in Minneapolis, Minnesota. It's a great workshop concentrated on the MMPI family of instruments. The SPA, Society for Personality Assessment, frequently at its annual conference has information on the MMPI-A-RF. And there are a variety of other workshops that are offered either as webinars or in-person workshops during the year. Of course, another place to get information about the MMPI-A-RF is in the manual, which is in the manual title is MMPI-A-RF Administration, Scoring, Interpretation, and Technical Manual. That's a long title. It covers administrative issues like the age ranges and reading requirements of the test, ways to score it, interpretation process, including case examples. But it also, at the end, contains a technical section that provides data concerning 17,000, roughly, analyses that were done with the MMPI-A-RF scales, calculating things like reliability data, alpha coefficients, correlations between ARF scales and external correlates in both clinical and normative settings. There is a user's guide to help you get the most out of using the scoring report and the interpretive report that's available from Pearson for the MMPI-A-RF. There is a book that's available through Routledge, which is a subdivision of Taylor and Francis, that I wrote and was published in 2017. That is a review of the MMPI-A and an extensive introduction to the MMPI-A-RF, including a comparison of the 2 instruments and the presentation of a number of cases scored on both instruments. That book is available through vendors like Amazon.com and Barnes & Noble, and of course through the publisher, Routledge Press. There is the University of Minnesota Press Test Division, again at their website, provides an updated list of research that has been done on the MMPI-A-RF, and this, I believe that you may have gotten a copy of this if you registered for today's webinar. So that's some quick information in terms of how to get basic information on the ARF. We're now going to talk a little bit about the MMPI-A-RF, but we're going to start by talking a little bit about the history of the MMPI in general. The MMPI was developed the process began in the late 1930s by Stark Hathaway and McKinley at the University of Minnesota. The test was formally published in 1943. Its working title was actually the Medical and Psychiatric Inventory, which is a title that I think actually would have been better than the Minnesota Multiphasic Personality Inventory in terms of describing what the test does. And as I'm sure you all know, it was based on empirical keying. This has led many people to talk about the MMPI, the original MMPI, as though it were atheoretical. It actually isn't atheoretical in the sense that the criterion group that Hathaway was using, the criterion groups, were based on diagnostic groups that existed in the 1930s. So that wasn't atheoretical. That was the development of a test that was meant to specifically predict two diagnostic categories. What was atheoretical or completely statistical was the selection of items that appeared that would be selected to appear on these scales. And of course, that's what the empirical keying or criterion keying method was about. I should also mention that Hathaway expected initially that the MMPI would produce essentially one elevation for people who had psychiatric disorders. So people who were depressed would produce an elevation on depression. People who were schizophrenic would produce an elevation only on the schizophrenia scale. He was, I think, surprised to find out that that was not generally true, and we'll talk about that in a few moments. But what he really wanted to do was to create a differential diagnostic tool to be used at the University of Minnesota hospitals. And he realized that if he could create an instrument that could standardize diagnosis and measure severity of diagnosis, that if it were given in a repeated administration, it could also be useful in measuring extent of recovery. And it quickly became the most researched and most commonly used objective personality measure in the world. Is it possible for an instrument to become too popular? That's an issue that we're going to come back to. But the MMPI had extraordinary success. Butcher and Owen in 1978 estimated that an astonishing 84% of all research on personality assessment tests were based on or focused on the MMPI. By the 1980s, it had been translated into languages for use in 46 countries, and there had been over 10,000 books and articles published on the use of the MMPI. Anne Anastasi described it in her seminal work, Psychological Testing, as the psychometric success story of the 20th century. And in a book that I did in 1987 and a survey that we conducted in 1991, we found that the MMPI was the most frequently used objective personality assessment instrument with adolescents. Adolescents have always been involved in one way or another with the original MMPI. It was originally intended for adults, but that was defined as people who were age 16 or older. Dahlstrom, in his Volume 1 of the MMPI Handbook, noted that the test could be used with adolescents as young as age 12 who were bright. And that actually has remained the advice for the ensuing 50 years. Research started with the MMPI even before it was formally published in the early 1940s by Dora Capwell, who looked at the elevations on the PD scale for groups of boys and girls who had been classified as delinquent. In the late 1940s, early 1950s, Stark Hathaway and the chair of the Department of Sociology at Minnesota, Marchese, conducted a massive study of adolescents in Minnesota and in Minneapolis that eventually involved 15,000 adolescents, including 3,000 or 4,000, if my memory serves me right, who were retested, initially tested in 9th grade, tested again in the 12th grade. And if we're talking about landmark works on the original MMPI with adolescents, work by Phil Marks, Seaman, and Deborah Howler in 1974, produced the first code-type correlate data for the MMPI and the adolescent population, and published a set of adolescent norms that had been developed by Phil Marks and Peter Briggs. The MMPI-A was subsequently developed in the late 1980s and published in 1992 because of a perceived set of problems in using the original MMPI with adolescents. One of those problems certainly was that there was no official set of adolescent norms that was designated for use with the test when it was applied to adolescents. Secondly, there was a need to revise the item pool to eliminate offensive items, defined as items that had to do with sexual orientation, for instance, or religious beliefs, but also inappropriate items like, as a child I played Drop the Handkerchief, which I spent 30 years trying to explain to adolescents, none of whom had a remote idea what Drop the Handkerchief was. Need to create skills sensitive to adolescent problem areas and developmental issues, and in general, I guess, most importantly, to try to standardize the way MMPI assessment practices were conducted with adolescents, which up until the publication of the MMPI-A had been very diverse. So in the late 1980s, a steering committee was created by the University of Minnesota, which resulted in 1992 in the publication of the MMPI-A. It was shorter, at 478 items. It retained the basic scales. It not only retained them, but an explicit goal was to leave the basic scales alone as much as possible, except for minor item rewording to improve clarity. It was, we developed a set of new adolescent norms that were collected across 8 settings in the United States, resulting or based on 1,620 adolescents. New items were added to the test for the first time that were specifically related to adolescent development. And so we ended up also with 15 content skills and 6 supplementary skills. And it rapidly became the most widely researched and used self-report measure of psychopathology for adolescents, just like its predecessor had. It did, however, also maintain the clinical scales for better or worse. The better part was that there was a research literature by Mark, Seaman, and Howler on the clinical scales. The bad part was the psychometric problems that exist in the basic scales were just carried over to the MMPI-A. What were those problems? Well, the problems in the basic scales were involved several factors. One is there is a common factor that is present in almost all self-report measures of psychopathology, which Alcatelican called demoralization, which accounts for almost half the variance, test variance, and confounds the interpretation of most test instruments. This overlap was made worse with the basic scales because of the degree of item overlap. For example, the item, I do not seem to be as happy as others appear to be, appears on 6 different scales on the MMPI-A, including 4 of the basic scales. This produced excessive correlations between unrelated scales. Scales like, for instance, scale 2 and scale 8, which should not be highly correlated, end up having a significant correlation. And within scales, there was substantial heterogeneity. There was the presence of the first factor. There was typically several content areas that were involved, some of which had not much to do with the construct that was the target of the scale. Certainly not from the point of view of the diagnostic criterion groups that were used as the criteria. And over the years, a number of methods were developed to kind of adjust for these problems. Because individuals typically produce elevations on multiple scales, we developed a codetype approach. Paul Meals wanted a good cookbook to interpreting the MMPI that allowed us to deal with multiply elevated profiles. The Harris-Lingos scales were developed in the 50s, I think, or the 60s, to break out the content sub-areas of the basic scales so that we could tell what was producing the elevation, particularly for scores that were in the marginally elevated range. And then, of course, interpretation was assisted by a variety of supplementary scales as well. In 2007, the University of Minnesota Press asked a number of individuals, myself and Rick Handel from Eastern Virginia Medical School, Yossi Ben-Forth from Kent State, Olga Teligan from the University of Minnesota, to begin work on an MMPI-A-RF. The purpose of this project was to develop a test that reduced the high degree of MMPI-A scale intercorrelations, to reduce the redundancy that results from the influence of demoralization factor, to reduce the amount of item overlap that occurred between scales, and to reduce within scales the multidimensionality that confounded the interpretation process. We also, from the outset, had a goal of developing a test that was no longer than 250 items, because test length had become an increasingly important issue in people's willingness to use the test, I think, particularly, for example, in educational settings. We also wanted to develop an instrument that was, in a sense, a downward extension of the MMPI-A-RF, but adapted to include measures that we uniquely found in adolescent development and psychopathology. So, in other words, very similar to the relationship of the MMPI-A to the MMPI-2. And finally, we wanted to create a test which was based on contemporary psychometric theories concerning psychopathology, not the diagnostic categories that were available in the 1920s and 30s. Now, I'm going to go quickly because I'm assuming you know this. To develop the MMPI-A-RF factor analysis we used to identify, the first thing we did is try to identify demoralization factor and then to isolate it and remove it from the basic scales as much as possible. Identifying major distinctive cores of the RC scales and the specific problem scales, and in creating the test and the scale structure, we used the MMPI-A-RF as a template. The overall objective was to increase the efficiency of the MMPI-A on the ARF by increasing its construct validity and particularly by increasing its discriminant validity. The overall strategy was to identify the demoralization factor, restructure the clinical scales, minimizing the influence of demoralization, and then augment the RC scales with additional measures such as the specific problem scales and the Psi-5 scales, using the MMPI-A-RF as the template. We use correlational analysis to augment the seed scales, so in other words, the seed concepts of the RC scales. If the scale items were retained, if it produced increased convergent and discriminant validity and alpha coefficients. Perhaps most importantly, we also developed the test on a paradigm that was based on modern psychometric theory, not on the diagnostic categorical model that had been used for the MMPI and the MMPI-A. And this leads me to talk a little bit about the shift in and the theoretical orientation to psychopathology that's occurred over the past few decades and what that means for the test instrument. The difference between the basic scales on the MMPI and the MMPI-A-RF is the difference in many ways between a categorical versus a dimensional model of psychopathology. Categorical models were based on the categories of mental disorder that were developed in the early 1920s and still reflected and elaborated in the DSM and in the ICD. In that model, one either suffers from schizophrenia or they do not. They suffer from post-traumatic stress disorder or they do not. It is a categorical model. It's a dichotomous model. It's a model that's widely used in medicine. One either suffers from cancer, for example, or they do not. There are problems with the categorical model. One of the problems is that there is comorbidity, so that patients typically meet the criterion for more than one diagnosis in the DSM. The measurement, the categorical measurement model doesn't necessarily reflect the nature of psychopathology as we understand it today. Most psychiatric syndromes are viewed as occurring across a dimension, not as dichotomous, so that it is very meaningful to talk about varying degrees of anxiety rather than one has an anxiety problem or one is free from any anxiety problems. It occurs along a dimension of severity. There has also always been the problem that the DSM diagnoses, it has been argued, and I think persuasively, often have limited predictive value in terms of helping us to predict an individual's response to treatment or, for instance, response to medication. And finally, because of the way that the DSM works, we typically are, for instance, making a diagnosis if the patient has 5 of the following 8 characteristics or 3 of the following 5 characteristics. That means that in the same diagnostic group, there are a lot of different ways of qualifying for that diagnosis, and leading to very heterogeneous diagnostic groupings, even for the same diagnostic category. Excuse me. The new paradigm reconceptualizes that the distribution of psychopathology occurs along a continuum, and that symptoms or constructs are best viewed as dimensional. The new paradigm also thinks about psychopathology as hierarchical in nature, ranging from, at the top, very broad categories of symptomatology and moving into increasingly narrow categories as we move down the hierarchy. What does this look like exactly, this kind of hierarchical model? Well, this is what it looks like on the MMPI-A. We have, at the very top, very broad models, very broad measurement categories. Emotional internalizing dysfunction, which covers the entire domain of problems in terms of feelings or emotions. Thought dysfunction, which covers the broad domain of any problems in cognition or thought processes. And behavioral externalizing dysfunction, which is a broad category covering any behavioral disturbances. At the second level, the RC scale level, we have more narrow domains covering more specific areas of dysfunction. And then at the third level, the most narrow level of measurement, the specific problem scales, we have the most narrow, most focused aspects of psychopathology. The MMPI-A-RF is 241 items in length And those 241 items were derived from the 478 items that appear on the MMPI-A. I'm going to go over this quickly because I assume you already know it. The MMPI-A-RF norms are based on the MMPI-A norms, dropping 10 cases from the A norms so that we have equal number of boys and girls. The administrative age ranges are generally for the A and A-RF the same. The validity scales are more elaborated on the A-RF, and critical item list that appears on the A has been carried over to the A-RF. Item overlap, which is an important area. Item overlap does not occur on the A-RF on scales within the same level of the hierarchy, the three levels of the hierarchy. So in other words, items appear on one and only one RC scale. Items appear on one and only one higher order scale. Items appear on one and only one specific problem scale. The gender for the norms for the MMPI-A-RF, unlike the A, are non-gendered, although you can break them if you wish separately by gender as an option. And the critical cutoff for the A-RF is 60 versus the 65 standardly used on the MMPI-A. So we're going to talk a little bit about a summary of criticisms of the MMPI-A-RF. Some of these are my expectations of criticisms based on what has been the topic of criticisms of the 2RF. The first one is the criticism that's been leveled at the MMPI-2, which will be leveled at the MMPI-A, or certainly applies to it, which is due to the substantial structural changes in the MMPI-A-RF. The codetype literature, for example, that Mark, Seaman, and Haller developed for the MMPI is not applicable. And the response to that is that's correct. It is not applicable. And in fact, one of the purposes of developing the A-RF was to reduce the amount of multiple scale elevations, to reduce the need for multiple scale codetype interpretation. On the A-RF in particular, I think the loss is limited in the sense that the codetype interpretation literature that was available for the A was almost exclusively based on Mark Seaman Haller's 1974 book without replication. So it was a relatively limited codetype literature that one is giving up. Construct drift. Well, if the MMPI-2-RF has construct drift, then the MMPI-A would have construct drift, meaning that the RC scales measure constructs that are different than those that are measured from the parent scale, and that is correct. Nathan Weed has pointed out that one person's drift may well be another person's zeroing or fleshing out or narrowing the focus of a scale to make it more homogeneous, which is exactly what I think the RC scales are. So are they identical to the clinical scales on the MMPI? No, they were created so that they wouldn't be identical to the clinical scales on the MMPI. They would be more focused, more narrowly defined. The influence of overlapping items and demoralization would be eliminated or reduced, and that was the purpose of the revision. A criticism that was leveled at the MMPI-2-RF was that it produced a higher rate of within normal limits profiles. I think in part that was due to a misunderstanding of what the purpose of the MMPI-2-RF was, which was to produce fewer clinically elevated scales than the MMPI-2 by the removal of the demoralization factor. But this particular argument is not accurate, I think, in any way for the MMPI-A-RF. That is, the rate of within normal limits profile for the MMPI-A-RF is actually substantially lower, that is, normal limits profiles for people in clinical settings, is substantially lower for the ARF than it is for the MMPI-A. Limited data. This is the criticism I have seen specifically attached to the MMPI-A-RF. And I think that it fails to make a distinction. I think that's not actually what the critics mean. There are 17,000 data analyses that are reported at the end of the MMPI-A-RF manual, which I think certainly counts as a substantial body of research literature on the test instrument. I think what the researchers mean is that there haven't been a large number of independent researchers that have done research studies on the MMPI-A-RF, and that is accurate given the fact that the test was published about 2 years ago. There's an ever-growing number of independent researchers, however, that are working on the test, and I suspect that just like with the MMPI-2-RF, the MMPI-A-RF will across time attract a significant body of independent researchers evaluating the validity and reliability of that test instrument. Is a test, I want to come back to this issue of, is it possible for a test to be too popular for its own good, I guess is the way I would finish that sentence. Hathaway in 1960 made the following statement: our most optimistic expectation was that the methodology of the new test, meaning the MMPI, would be so clearly effective that there would soon be better devices with refinement of scales and general validity. We rather hoped that we ourselves might, with 5 years' experience, greatly increase its validity and clinical usefulness, and perhaps even develop more solidly based constructs or theoretical variables for the new inventory. Hathaway was therefore, clearly talking about the need to periodically revise and expand the MMPI. In 1972, in a book on the future of the MMPI, edited book, Hathaway wrote a chapter, and in that chapter he said in another 12 years, he was referring to what he had said in 1960, were we to go by without our having gone on to a better instrument or procedure for the practical needs it fulfills, I feel that the MMPI, like some other tests, might have changed from a hopeful innovation to an aged obstacle. So I certainly think that Hathaway was a person who was thinking in terms of change across time for the MMPI family of instruments. And the dangers of a test becoming so popular that it became frozen in time. I'm going to do a brief discussion of administration and interpretation guidelines. And again, I'm assuming that the audience that's listening to this webinar is familiar with the basics in this area. The MMPI-A-RF has 48 total scales, 6 validity scales, and then substantive scales, which are anything that's not a validity scale. These include the 3 higher order scales, the 9 RC scales, the 25 specific problem scales that are organized into 4 groups, and the 5 sci-fi scales. These are the validity scales. We have a set of 3 scales that deal with response consistency. And we have 3 scales that would, in my mind, deal with accuracy. F revised, dealing with the issue of over-reporting. L revised and K revised, dealing with the issue of under-reporting. The validity scales are interpreted sequentially. That is in the order that they appear on the profile sheet. We start with the issue of content non-responsiveness. We then move to the issue of over-reporting, and then as we move from left to right on the profile sheet, the last 2 scales have to do with under-reporting. So you follow the format of the presentation of the scales on the profile sheet in your interpretation strategy for the validity scales. There are 3 higher order scales. They are the broadest level of the hierarchical structure of the test. They provide estimates of the adolescent's functioning within 3 very broad domains. And those are followed at the second level by the RC scales. The second level of the hierarchy, uniformly shorter than their counterparts on the MMPI-A basic scales, and also probably uniformly shorter than their counterparts on the MMPI-A-RF. The first 5 RC scales and the last 4 RC scales. And again, I'm not going to go into the definitions or item content of these scales because I'm assuming that you know that information. And then we go at the bottom level, the third level, the most specific level of the hierarchy, to the 25 A-RF specific problem scales, most narrow range or level of the hierarchy, organized into 4 broad subcategories. Can be interpreted, that is, elevations in the specific problem scales can be interpreted, even in an absence of elevations on the comparable RC or higher order scale. So we have 5 scales that have to do with somatic cognitive distress, ranging from 4-item gastrointestinal complaints to 8-item malaise scale. We have 9 scales measuring various aspects of RCD demoralization, RC2 or RC7. They range from a 3-item brief restricting fear scale to a 10-item helplessness scale. So again, they're feeding off either demoralization, low positive emotions, or dysfunctional negative emotions, RC7. And I tend to think of this as pulled-down menus. So we start at the highest level, higher order scales. We pull down, if that is significantly elevated, we pull down the menu to the second level, RC scales, and then we use the pull down menu to the specific problem scales. We have a series of 6 externalizing scales that measure various aspects of RC4, antisocial behavior, or RC9, hypomanic activation. They range from the 4-item substance abuse scale to the 2-item aggression scale. 5 of these 6 specific problem scales are measuring aspects related to RC4. One of them, aggression, is related to RC9. There are 5 scales under the interpersonal domain. All of them relate to the adolescent's interpersonal functioning as it is related to his family or his peer group, ranging from the 4-item interpersonal passivity scale to the 11-item family problem scale. It's worth noting in passing that family problem social avoidance and shyness, for example, are among those scales that can be interpreted both in terms of low scores as well as high scores. Before we leave structural issues, let me mention that the Psi-5 scales, a set of Psi-5 scales were developed for the A-RF by the same authors of the Psi-5 scales for the MMPI-A, MMPI-2, MMPI-2-RF, namely Alan Harkness and John McNulty. We gave Harkness and McNulty our 241 item pool for the MMPI-A-RF and asked them to develop, if they could, a set of non-overlapping Psi-5 scales using the same methodology that they used to develop them for the other MMPI instruments. And they did, I think, a great job of doing that. And we ended up with 5 scales that range from a 13-item psychoticism, a negative emotionality scale, to a 20-item disconstraint scale. We also carried over the critical item list developed by Jonathan Forby and Yossi Ben-Porth for the MMPI-A to the MMPI-A-RF. We found that 53 of the items on the MMPI-A critical item list were also found on the ARF, reflecting 14 of the original 15 content areas that were found on the MMPI-A. So we have 14 areas and 53 items. They're not scales. They are areas that are very useful in terms of focusing feedback questions to the adolescent and providing insight into the specific types of psychopathology and symptoms the adolescent is endorsing. Computer-based test interpretation. There is, of course, a CBTI program available from Pearson for the MMPI-A-RF. For the MMPI-A, there is an interpretation package from Pearson, and there's also one from PAR for the MMPI-A. And rather than go into detail, let me just summarize by saying a couple of caveats about using computerized test interpretation. One is that all programs that are written, all of them, for the interpretation of MMPI scales are a combination of actuarial data, that is data based off of empirical sources, combined with the clinical judgment of the person that's writing the program. And therefore, it's critical for test users to be aware of who wrote the content of an interpretation package. And the other thing that I would mention is that buying a test interpretation program or package is in many ways like buying a TV set or a refrigerator or any other product. And so all the things that we know about buying products are important. The support services that are available to support the use of that product are critical, as is the commitment of the company that's marketing it to revising it and updating it periodically so that it can incorporate in new research findings. This is the MMPI-A-RF interpretation sheet, which can be found in the MMPI-A manual, can be found in any of the scoring or interpretive reports by Pearson. And it's, I think, an excellent way of organizing your thinking about the MMPI-A-RF interpretation process. It begins with the protocol validity, where we should always begin interpretation, and then moves on to a series of domains, the 3 higher order scales: emotional dysfunction, thought dysfunction, behavioral dysfunction, 2 other domain areas: somatic cognitive dysfunction, interpersonal dysfunction. And within each domain, as we move over to the right, we get to hierarchical levels, a movement across hierarchical levels within that domain. So for instance, for thought dysfunction, we start with the higher order scale, thought dysfunction. We move to RC6 and RC8, RC at the second level, RC scales related to thought dysfunction. And then we move to the Psi-5 scale psychoticism. So domains, each of the domains, and within each domain, the hierarchical working across the hierarchies related to that domain. And this is what the MMPI-A-RF T-score printout looks like in the MMPI-A-RF Pearson scoring and interpretive report. And we'll talk more about that in just a second. But it's the same information as in the previous slide. And so to kind of summarize, MMPI-A-RF interpretation begins with higher order scales. If only one is elevated, you use that as the starting point to interpret. and then you move to the RC scales, specific problem scales, and Psi-5 scales. When interpreting the RC scales, you proceed in the order of elevation of those, incorporating in the relevant specific problem scales and Psi-5 scales. If more than one higher order scale is elevated, which was going to be true in the clinical examples we're using, use the highest one as the starting point, then proceed to the next highest one. If no higher order scale is elevated, proceed to the RC scales and interpret by domain. Once higher order scales and RC scales are covered, interpret all remaining specific problem scales and the interpersonal and interest scales. And always, you end up using all of that information to formulate diagnostic and treatment considerations for the adolescent. This is, I think, a very useful way of organizing your thinking, and I think you also got access to this when you signed up for the webinar about interpreting the MMPI-A-RF, put together from the University of Minnesota Press, and I think Katie Nickerson had a major role in creating this form. And it's available from the University of Minnesota Press Test Division. And so this gives you space. It organizes the way that the scales should be interpreted and gives you space, particularly as you're learning the test, to write out your findings and keep you focused on the most relevant aspects of interpretation. All right, so we're 3 minutes off my time schedule. I'll take that as a moral victory. And we're now going to talk about the first clinical case example, which is Brenda. Brenda is a 16-year-old girl who was referred for an outpatient evaluation. In this case, because she was receiving care at a children's agency for severe parent-child conflict, had a history of conduct disordered behaviors, severe parent-child conflict, had a history of depression, which included several suicide attempts, drug abuse history, sexual acting out, defiant and oppositional behaviors. And this is actually the first case that we used in the manual on the MMPI-A-RF. This is the cover sheet for Brenda. If you selected, if you wished, you could select a comparison group for Brenda, which would be, in this case, out of the 10 comparison groups available in the interpretive package. In this case, there is a comparison group for girls evaluated in outpatient settings, which would be obviously the most relevant for her. And this is her validity profile. So we start always at cannot say. Cannot say in this case is 2, which doesn't mean that we can't interpret the protocol overall, but does mean that we may have one or more scales that do not meet the criterion of having 90% of their items or more answered in order to interpret a within normal limits score on that scale. As we're going to see in this particular case for Brenda, there is a scale that's affected by the item omission. We then look at the 3 scales that have to do with consistency, FRIN-N, TRIN-N, TRIN-R, FRIN-R, and CRIN, all of which look like they're between 40 and 50, and therefore there's no issues with consistency of her responses. And finally, issues related to the accuracy of her self-report. She has a 69 on F, which is certainly not invalidating this response, nor necessarily indicating any kind of over-reporting. It is, in fact, a score that you might expect given the severity of her history. In fact, in that regard, it might even be a little low given the severity of her history. And on measures of defensiveness, she produces very low scores. Again, no evidence of defensiveness. In fact, her K-score is so low that it may reflect a certain degree of self-criticalness. And this is her profile, which is what makes this complicated. It's complicated because there are elevations on multiple scales. There are elevations on multiple scales in this case, not because of confounding or high intercorrelations between scales, but because this is legitimately a case of an adolescent who is producing symptomatology across a variety of domains. So we begin with the higher order scales. We note that there are two elevated. One is emotional internalizing dysfunction at 77, and the other is behavioral dysfunction at 62. Using the rule of thumb of interpreting that most elevated higher order scale, we start with emotional internalizing dysfunction. If we did that, we pulled down, again, my analogy about a pull-down menu, on the second level to three scales. RCD, which is at 93, RCD, which is at 77, RC2, which is at 93, markedly elevated, and RC7, which is not elevated. It's below the critical cutoff of 60. The most elevated scale is RC2, so we would begin interpretation there. And flipping over to the Psi-5 scales, for example, we would notice that introversion low positive emotionality is markedly elevated at a T-score of 99. Going back and looking at RCD, demoralization, the second most elevated scale, we could look at the internalizing scales and see that Brenda has elevated a number of them. Helplessness, hopelessness at 80, self-doubt, at 74, inefficacy at 61. But I want to stop for a second and note that this is bolded. The percentage of responses is bolded for inefficacy because this is where those two item omissions had an impact. The inefficacy scale, 25% of the items were not endorsed at all. This gets interesting then. If this scale was 55, if the T-score is 55, my advice would be don't interpret it because it's not clinically elevated and we don't know why. It could be because of missing items. However, in this case, it actually is clinically elevated even with 25% of the items missing. So it is fair, I think, to say that you could note that inefficacy, a sense of not being powerful or being powerless in controlling the world around you, having an impact on the world around you, is a significant issue, although it may be even more significant than is indicated by the test results because of the missing items. So in other words, you can interpret an elevation, but you should qualify it by the fact that it could be even higher if all items had been completed. In addition, anger, proneness is at 74, and negative emotionality on the Psi-5 scales. Oh, one too many. Negative emotionality on the Psi-5 scales is at 60. And finally, RC7, dysfunctional negative emotions, is not elevated as we said before, nor is any of the other scales related to it with the exception of anger proneness, which is at 74, and negative emotionality and neuroticism on the Psi-5 scale. So there are, we're going to try to put all of this together in a second, but there are a number of aspects of emotional dysfunction that clearly are strongly affecting Brenda's psychological functioning. She also has a significant elevation in the area of externalizing dysfunction. And the two RC scales that reflect this are RC4, which is at 85, significantly elevated, and RC9, which is not significantly elevated at 58. RC4 pulls down to a number of externalizing specific problem skills. And then specific, it pulls down to negative school attitudes, conduct problems, negative peer influences. All are significantly elevated, as are the Psi-5 scales, aggression and disconstraint. Brenda's scores on thought dysfunction were not elevated, nor are they elevated in RC6 or RC8, so as we'll talk about more in a moment. The one area of broad area of psychological functioning Brenda does not have problems with has to do with her cognitive processes and thought dysfunction and psychotic-like symptoms. We can now go on to the other domains that are available for interpretation on the test. The first one being somatic cognitive, and it's noted that she produces a elevation of 72 on this scale. And when we flip over to the somatic scale, she elevates all of them: malaise, gastrointestinal, head pain, cognitive functioning. All of those scales are elevated with the exception of neurological complaints. So somatization is going to be a significant defense mechanism for Brenda, in addition to acting out. And finally, there is the domain, interpersonal domain. I tend to look at cynicism as relevant in this area. So we would look at RC3 and find that she has a cynical attitude concerning others. She sees them as being manipulative, as people being motivated by their own self-gain. And in terms of her scores on the interpersonal scales, she produces a marked elevation on family problems, which is certainly consistent with the background that I read to you at the beginning, and social avoidance. These are the Psi-5 scales, which we have talked about in terms of their relationship to the RC scales and higher order scales. This is, I want to take a second now to talk about the MMPI-A-RF T-scores by domain interpretive sheet, and to draw to your attention that in the interpretive report, scales that are elevated above 60 are bolded. And I love this feature. And the reason that I like it is because it makes it possible for you to glance at this form and immediately kind of get a sense of what is relevant and what is not relevant in terms of describing Brenda's psychopathology. So, for example, we can quickly see that scales related to validity are all within non-problematic ranges. And we can see, for example, that thought dysfunction none of that is bolded. So none of the aspects of thought dysfunction are going to be particularly relevant to Brenda's experience of psychopathology. In contrast, the somatic cognitive domain has a number of scales bolded. The emotional dysfunction area has a number of scales bolded, and so does the behavioral dysfunction area. So let's try to put all this together and say something coherent about Brenda. First of all, it is a complex case because there's so many things going on in terms of her psychopathology. She has internalizing scale values that indicate substantial emotional distress, marked depression that involves suicidal ideation. And we're going to take a look at a second at a critical item list related to suicidal ideation, try to get a better sense of how much of an issue that is. But it certainly has been an issue in the past with her, and one that needs to be monitored. She also has a significant number of elevations on the behavioral externalizing problem domain. That include problems in anger, control, disconstraint of her impulses, negative peer group influences, a lot of family conflict. And finally, she uses somatization as a primary defense mechanism. She chronically feels she has kind of poor physical health and malaise. She feels weak, she has head pain, she has gastrointestinal complaints, she has fatigue. Diagnostic categories that are going to be relevant to Brenda certainly would seem to me to be related to major depressive disorders, affective disorders generally, but major depressive disorders, and the behavioral aspect of it captured by conduct disorder. There's also as I mentioned before, the need to evaluate her suicidal potential and immediate risk. Now, because of copyright on scales, the actual items are omitted, but I can cheat a little bit and I can tell you under depressed suicidal items that she endorsed item 46, I sometimes think about killing myself. True. Item 155, most of the time I wish I were dead. True. Item 119, the future seems hopeless to me. True. And so the items that are directly related to suicidal ideation are bolded in the printout from Pearson. It's interesting, under family problems, she endorsed true item 180, which is I hate my whole family. So that is an overview of Brenda. And the next case that we'll try to take on is Joe. Joe is a 16-year-old boy from a lower white SES background in a large urban area. He was referred after getting arrested when he broke into a public high school and conducted some vandalism and destruction of property. He was arrested, placed in detention, and was released to the custody of his family pending his hearing. At that hearing, he was convicted. And following his conviction, this adolescent was referred by the Juvenile Domestic Relations District Court judge for a psychological evaluation prior to sentencing. That is the most frequent reason for a referral of an adolescent in juvenile justice system. That is a referral prior to sentencing to help a judge make some sense out of the sentencing for the adolescent vis-a-vis their psychological needs. So we'll see if we can do that based off of Joe's test results. It could be noted that Joe also had a prior history of 2 school suspensions for fighting and an educational record marked by uneven academic achievement, academic underachievement actually, and by a history of behavioral problems in school. This is the cover sheet for Joe. Again, if we were using the MMPI-A-RF interpretive report, we'd have an option of choosing a comparison group from 10 comparison groups available. The one that would be most relevant for Joe would be the comparison group based on a large sample of boys in pre-adjudication forensic settings. So that is an option that could be pursued. What would that option do? It would give us the mean and standard deviation for the comparison group across all of the scales and where Joe placed in a percentile value on each of the scales against that comparison group. Validity scales, place that you should always start when you're interpreting an MMPI, any form of MMPI. Measures of consistency, like for Brenda, measures of consistency are all well within normal limits. And I should mention that the cannot say score is 0, so that's very nice in the sense of not being a factor in our interpretation. Consistency measures are all well within interpretation guidelines, and measures of accuracy, either those having to do with over-reporting a revised F scale or under-reporting the revised L and K scales, all well within normal limits. So we have enough responses, we have consistent responses, we have accurate responses, and therefore we have a validity profile that's consistent with us being able to provide a meaningful interpretation of the substantive scales on the ARF. Joe, like Brenda, produced 2 elevations on the higher order scales, and those most elevated scale was thought disorder at 76. Second most elevated scale was behavioral dysfunction at 72. So Joe has a combination of some unusual thoughts or ideation combined with a history of behavioral problems and acting out. We should start with thought disorder, higher order scale, because it's the most elevated. If we do that and we do the pull down menu from this higher order scale, we go to 2 RC scales that are pull downs. They are RC6, which is markedly elevated for Joe, and RC8, which is not. So we have an interesting combination. Joe doesn't produce a significant amount of aberrant experiences, with the exception that Joe has a significant presence of kind of persecutory ideas. He's vulnerable to real or imagined threats, is the way that Phil Marks described elevations on scale 6. And this correlates for boys, and I think unsurprisingly in a lot of ways, if you think about what that would be like to be a male adolescent, particularly in a criminal justice setting, who feels that they are oftentimes subject to aggressive behavior by others, insulting behavior by others, derision by others, that it correlates elevations on the scale, therefore end up correlating with aggressiveness, assaultiveness, and fighting. Joe also elevates behavioral dysfunction. And of course, the pull downs for this on the second level are RC4 at 71, clinically elevated, and RC9 at 52, which is not elevated within a clinical range. If we pursue the RC4 elevation over to the externalizing scales, we note that he produced elevations on negative school attitudes, antisocial attitudes, conduct problems, that he produced elevations on negative peer influence and aggression. So in other words, all of the externalizing scales, with the exception of substance abuse, are elevated by him. If we look over at the Psi-5 scales, we note that he also elevates aggressiveness and disconstraint. So this is an adolescent that has significant behavioral problems, antisocial attitudes, conduct problems at home and at school, negative peer group issues, and use of aggression to obtain objectives, combined with poor impulse control. We can now move on to the other domains, and if we would probably next go to somatization. RC1 is not even close to being elevated, and none of the somatic cognitive skills fall within the elevated range. We could also look, I should have done this earlier, but we could look at the scale that is not elevated just to see if anything else is going on there. So the emotional, just because emotional dysfunction is not elevated does not automatically mean that other scales can't be elevated related to it at lower levels in the hierarchy. And if we do that, we would note that RCD, start with RC2 and RC7, are all within normal ranges. And all of the internalizing scales are within the normal range, with the sole exception of anger proneness, which is at 74. And if we flip over to the related RC scales, negative emotionality, introversion, those sci-fi skills are both within normal ranges. So this adolescent clearly has very few symptoms that are related to internalizing emotional distress. In fact, the only symptom that we can identify in this MMPI-A-RF protocol is anger proneness, which is consistent with what we saw when we looked at his behavioral dysfunction related skills. The last domain that we can look at is interpersonal functioning, skills that are related to his relationship to his family or to his peer group, and all of those skills are within normal limits. The only one that is not is disaffiliation, which is at a T-score of 58, close to being clinically elevated, close to really a level in which we could talk about his kind of disinterest in people. But it doesn't reach a clinically elevated level. And we've talked about, I think, all of the Psi 5 scales now as we worked our way through the protocol. This is the MMPI-A-RF T-scores. And again, you can see at a glance. Validity scales are non-problematic. Somatic cognitive, there's no bolding that's occurring. Emotional dysfunction, nothing going on there except for anger proneness. Thought dysfunction has significant issues. Those issues appear to be related primarily to RC6, persecutory ideation, and a lot of behavioral problems going on. So how would we summarize Joe? Well, Joe's test results indicate that we should give a lot of consideration to diagnoses involving externalizing disorders, various forms of conduct disorder. Further, this adolescent has impulse control problems related to anger and aggressiveness, and these impulse control problems and anger may well be triggered by real or imagined perceptions that he's being treated unfairly, he's being disrespected or humiliated. It's interesting to speculate what kind of background Joe may be coming from that has built up that kind of hypersensitivity to insult. Anger management and increased behavioral control will be primary treatment targets. And because this adolescent has poor impulse control, that whatever the judge's decisions are regarding sentencing, probation, or parole options should be pursued for this adolescent in a manner that place some external controls and mechanisms for monitoring behavior on external sources, because Joe's own ability to control his behavior at this time or to accurately monitor his behavior appears to be pretty defective, pretty immature. So we've come in at 1:16. I was 1 minute off in my time estimates, and we have 14 minutes left for questions.
Hey, Dr. Archer, this is Deb. Can you hear me?
I can.
Excellent. I wasn't quite sure if you were going to go over the, I know there are a couple of other case examples, so we did not yet send a call out for questions. So I'll do that right now. If anybody has a question for Dr. Archer at this point, just type it into the chat box.
Oh, good.
And we'll address, yeah, we'll address it since we've got time here. Did you want to say anything about the additional cases at the end? Mentioning that they're there?
Yeah, what I would say is,
right? Yeah.
I really wasn't very sure how long this presentation would take, so I put some cases at the end in case I got into the train station early, and that's why they're there. And you can ask me questions about those cases. I'll try to answer them, but we did not make it to those cases.
Okay.
Actually, go ahead.
Yep. No, go ahead.
I was going to say that I hope maybe we can change out these cases across time when I do this webinar again.
Great. Yep, absolutely. So thank you for a very informative presentation, and especially the focus on the case examples. So we do have some questions coming in here. Your couple of cases that you did go over were more in a clinical setting. But earlier you had mentioned the educational setting and the length of MMPI-A being a barrier to use. Are there specific scales you see as particularly useful in the ARF for the educational setting, since most evaluations are for categorical special education eligibility?
Well, sure. I mean, I'm not sure that they're unique to an educational setting, but many times adolescents get referred for an evaluation in a school setting because of behavioral problems. And therefore, all the scales that have to do with externalizing and the origins of that behavior and the accurate description of that behavior is useful. Less frequently, but I think very importantly, adolescents are referred for problems related to emotional distress. We miss those adolescents a lot in classrooms because they're not the ones that are in our face, and so they're probably under-referred. But all the scales that have to do with internalizing dysfunction are relevant for that. There is a scale among the among the somatic scales. There's a scale that's related to cognitive complaints that have to do, I think, that may well prove to be a very interesting scale in educational settings, that has to do with problems of memory and concentration and attention. And my guess is that adolescents that have attention deficit disorder issues will tend to elevate that scale. So I think in answer to your question, there is in fact a lot of scales that would be very relevant in an educational setting.
So related, this individual is curious if you've seen or if you recommend the use of the MMPI-A-RF as part of a comprehensive threat assessment of youth, either in or out of school.
A threat assessment. That's what you said?
Threat.
The question is, as a threat? Yeah, sure. I think that there are a number of dimensions that would be useful, although let me start by saying that the prediction of violent behavior in individual cases is exceedingly difficult and is not easily undertaken, and it can never be undertaken with complete confidence using any instrument that I'm aware of, or even any interview technique. So identifying children, adolescents, school-age children who are at risk for engaging in violent behavior is a very difficult enterprise. Usually it's because the adolescent said something that ended up with them being referred for an evaluation to try to determine the level of actual risk that's attached. Now, having said that, there are a number of scales, I think, that have to do with externalization on the MMPI that would be very useful. Although I must say that I should also qualify by saying that people engage in violent behavior for a wide variety of reasons, some of which have to do with mental health issues, some of which have to do with mental health issues related to behavioral disturbances, conduct disorder, antisocial behavior, some of which have to do with psychotic symptomatology, and some of which probably don't have to do with mental health issues as we normally think of them at all. So having put all those qualifiers in there, if I were evaluating an adolescent to try to get a sense of risk assessment, I certainly would be looking at it at the externalizing group of scales. I would be looking at disinhibition on the Psi-5 scale just to try to answer the question, can this adolescent control their behavior, control and direct their behavior? Or are they prone to, subject to impulsive behaviors in which they act first and think about it later? And then there are certainly all the scales that have to do with anger, anger control, anger proneness that I think would be relevant. But it is a very complicated thing to do a risk assessment either of an adult or an adolescent. And I don't want to in any way minimize the complexity that's involved in doing that.
Okay, lots of questions, actually a few here about Joe's case that you went over. Would we not consider psychotic spectrum diagnoses for Joe as well?
I think that would be a great rule out. But my guess is that Joe is not psychotic. And my belief about Joe, the first place that I would probably look is that Joe has come out of an environment in which being paranoid, if I can put it that way, is reinforced. Being hypersensitive to threat, real and imagined, pays off for Joe in a way that it didn't pay off, for instance, wouldn't have paid off for me when I was an adolescent because I was not at high risk to be shot by one of my peer group or beaten senseless by one of my peer group. But I'm not sure that Joe is in that situation. I think Joe may well be operating in an environment and in a peer group in which it is richly rewarded if you can pick up a threat early enough to stop something very bad from happening. So my guess is that Joe's hypersensitivity to threat has been a response he's learned as a way of surviving in his environment. And that would be my first guess. But should you rule out psychoticism? Sure. Is he delusional? And you could rule that out, I think, and get a sense of that very quickly in terms of something that's always critical with MMPI-A-RF, which is doing test feedback with the adolescent and asking them what they meant by their responses. Joe, when you said in this item that there are people out to get me, what did you mean by that? And that I can trust no one. What did you mean by that? Tell me about your thinking. And that, I think, would allow you to start getting a sense whether you could rule out psychoticism or not.
So another question about Joe. Somebody's interested in exploring criminogenic thinking styles with Joe. Would you say that you could address that with some confidence using the ARF?
I think you could address it using the ARF in combination with a clinical, with an interview. So if I understand that question, does Joe have attitudes and beliefs that support his engaging in antisocial behavior? Well, we know he does to some degree from the ARF already. For instance, we know that he's pretty cynical about the ways that people interact with each other. We certainly know that he's untrusting or distrustful in interacting with other people. It would be a pretty good inference that Joe may view any behavior as being within bounds because, after all, we're all out for whatever we can get away with in this life. But so does the MMPI-A inform us concerning thinking styles, cognitive styles that might support antisocial behaviors? I think it clearly, Joe's test results do. I think then we follow that up by talking to Joe about his attitudes and beliefs in that area, and we can refine our picture pretty quickly. But it's a good. All these questions are good. That was a good question.
Yeah, people are concerned about Joe. We have one more question. Seems remarkable that Joe is low on the substance abuse scale. Definitely worth mentioning, whether denial or, given his history, somewhat miraculous. Any thoughts about resiliency factors using the ARF?
Oh, what a good question. Well, I mean, you could look at the MMPI-A-RF broadly as a measure of resiliency in terms of the degree to which an adolescent's functioning is pathological versus non-pathological. So let me back up and say that the MMPI-A-RF, like every form of the MMPI, doesn't measure adaptive characteristics very well. It wasn't designed to do that. There was no criterion group of resilient adults, for example. And so all of the constructs that the MMPI generally measures have to do with problems in adaptation and if you would, failures in adaptation. So the biggest overall index of resilience that you would see in an MMPI-A-RF probably relates to how pathological the adolescent looks overall versus falling within normal ranges along most dimensions. But is there a specific measure of resiliency? No, there is not. Nor was the MMPI designed to do that. It was designed to measure psychopathology.
Okay, a general question about administration. This individual usually strongly stresses to the test taker to answer every item. Would you say that this could distort responsiveness?
Well, that's a great question. Let me, it may be the last question we have time for, but let me very quickly say, back in Hathaway's day, that would be considered terrible. And that's why in the MMPI original, in Hathaway's era, you had an average cannot say rate of about 30 items omitted from a test. But nobody does that today. And all of us, including myself, urge an adolescent to answer all the questions that they can. Now, I hasten to add that my instructions are to answer all the questions that you understand and can answer. If you have any questions, feel free to ask me. I can only answer questions that have to do with text, kind of definitions of words. So I don't want to force an adolescent to just fill in a blank true or false for an item they don't understand to follow my instructions. But I do want them to answer every single item they can. And if they hand me back a test protocol answer sheet that has 20 omissions, I might ask them to go back and take a look at those 20 items to see if there are any that they can answer. So it is common practice today with all forms of the MMPI to urge people to answer as many questions as they can. And that is these test instructions that are used for the development of norms, by the way. So I don't think it biases the responses in a way that distorts the adolescent's interpretation.
Okay, you mentioned we've got one more minute. Do you have time for one more question?
Sure.
We have
what
some
you
folks
got?
That are, we have some folks who are interested in some of the critiques that you were talking about and how they've evolved in a literature over time. Is there anything that you believe is sticking or anything that's been rebutted mightily in the literature?
Well, I actually think that all of the points that I raised have very good rebuttals. As I noted, the MMPI-A-RF really has, to date, the only critique that I know of, negative critique, is that it's typically stated as no research literature, which, again, I think is quite wrong, quite incorrect. What is absent is a large research literature by independent researchers not connected with the development of the test. But boy, there's a large literature on these critiques that occur in Journal of Personality Assessment, that occur, has a number of articles. If you did a search through JPA, you'd find a lot of critiques, including when the MMPI-A-RF originally came out. There was a great series of, I think, pros and cons about the MMPI-A that appeared in a special issue of JPA. Psychological Assessment and the Journal Assessment are the other places I would look, the three journals that are mostly concerned with the assessment literature. But there's a large body of literature on attacks and defenses of the MMPI-A. Much smaller on the MMPI-A because it's much more recent test.
Thank you. So that is all the time that we have. I want to thank you, Dr. Archer, for sharing your expertise with us today, and I want to thank everybody online for your interest in the ARF. There will be a survey as you exit. If you have any comments or additional questions that you'd like to submit via that vehicle, please do so. So Dr. Archer, thank you for
it was my pleasure.
Today.
I enjoyed it.